Hello, and welcome to the Clinical Liver Disease video series. CLD is an official digital learning publication of the AASLD. I'm Dr. Camilla Graham on the infectious disease faculty at Beth Israel Deaconess Medical Center and Harvard Medical School. And today I'm delighted to tell you a little bit about my paper entitled The Current Status of U.S. and Global Access to Direct-Acting Antiviral Regimens for Hepatitis C Virus Infection. The main point I want to make today is that when we got access to all oral regimens for hepatitis C, they were now finally able to cure the vast majority of our patients. There were things that went really well, and there were things that went terribly. My hope is that in the next 7 or so years, we are going to have equally transformative treatments for people living with hepatitis B virus infection, and that we will be able to recapitulate the things that went well with our rollout of direct-acting antivirals for hepatitis C, and that we avoid some of the mistakes we made and figure out how to circumvent some of the terrible things that happen with hepatitis C. Get a chance, get a do-over to do better with new regimens for hepatitis B. And that's the main point of this paper. I'll give you a couple of examples. So one, early on in our ability to have direct-acting antivirals that could be combined into all oral regimens, two of the major companies agreed to work with entities to allow the production of generic regimens for low-income countries. That was not perfect, but it was a good start, and it happened more rapidly than we've seen in most other diseases, possibly with the exception of HIV. Conversely, things did not go so well in middle-income countries. The drugs were priced at levels more appropriate to high-income countries, and these countries don't have the healthcare budget to have been able to afford them. So first off, thinking about more appropriately tiered pricing for full access for everybody. And then we all know in the high-income countries, the initial reaction of our reimbursers, the payers, was one of perhaps surprise, although it's unclear why, at the expense of these treatments. And I know for one, I experienced rationing of treatment for my patients that I had never actually experienced before. I do not ever want to repeat the heartbreak of what I started calling crying clinics, because my patients were so distraught that there was a regimen that was easy to take, well tolerated, that cured the vast majority of people, and they couldn't access it. I couldn't figure out how to get it reimbursed because of arbitrary restrictions that had nothing to do with the product label, that didn't have to do with strict restrictions in the guidelines. I will say, one thing we need to do better with hepatitis B is not provide guidelines that give payers a roadmap for restricting access to treatment. We need to make it clear who the appropriate patients are and what the appropriate limitations are, and inevitably there will be some appropriate limitations, and that's it. And anything else is arbitrary rationing, and we can't allow that to happen to the people that trust in our care. Another thing that went sort of well was there was a rollout of less expensive diagnostics. In many of the low-income countries that were able to get their prices of a full regimen down to something under $200 for a full treatment, we suddenly realized that the cost of the diagnostics themselves for diagnosing and monitoring treatment were higher than the drug cost. And there have been some interventions to try to get this down, and yet still getting data that's required for appropriate diagnosis and monitoring. We need to do better. In the United States, for example, in our alternative care settings like syringe exchange programs or methadone clinics, being able to access affordable diagnostics, especially for the detection of the virus itself, has been a challenge. With hepatitis B, I worry that this is going to be a similar problem. I imagine with any of the novel interventions that they are also going to require some degree of viral load monitoring or correlated antigen or some other kind of direct test of the virus. And these tend to be very expensive. So we need work now on affordable, high quality, preferably point of care, easy to administer diagnostics, and these aren't simple to develop. So work needs to be starting now to ensure that by the time we have access to these novel treatments for hepatitis B, the diagnostics are there to provide that support. So these are just a couple of examples. This is a short paper. I hope you enjoyed this video, and I hope that you look at the paper. And thank you for this series.